Good morning, everyone, and welcome to the inaugural Integrative Medicine Grand Rounds. This is quite an event for us. We're very, very excited to be beginning this series, and I'm just very, very thrilled to have you all here. The goal, I'm Helene Langevin, by the way. I'm the director of the Osher Center for Integrative Medicine. And I want to just tell you a little bit about what Integrative Medicine Grand Rounds is and what it aims to do. And its large aims are twofold. The big sort of overarching aim is to bring together clinicians from different medical traditions and foster a constructive dialogue and an exchange of ideas and language and expertise. And this is what we want to do. We want people to communicate and talk. We want to create a place, a forum to hold these conversations. And there's another goal, which is quite unique to our academic environment here at Harvard Medical School. We're very blessed and lucky to have not one but multiple centers for integrative medicine within the Harvard medical affiliated hospitals and institutions. And in addition to that, there are other centers for integrative medicine in the greater Boston area, at Boston Medical Center, at Tufts, that we have already ties to and links. And so we want to create an opportunity for these various groups that so far have not really had a chance, a venue that was a recurring venue where people could really come together and get to know each other and create a sense of being part of a community. So this is what we want to do. And today's Grand Round presentation is and I have to say a little bit about the format of the Grand Round. So they will center on a classic case presentation, presenting a patient case history and discussion. And there's going to be, obviously, we really want to have a lot of audience participation and discussions. So this is very much going to be a conversation and dialogue. So today's inaugural Grand Rounds presentation will be given by a representative of the Osher Clinical Center, Dr. Matt Kowalski. Dr. Kowalski is a chiropractor at the Osher Clinical Center and has advanced postgraduate training in orthopedics as well. He's the president of the New England Spine Institute and adjunct faculty at the National University of Health Sciences. And today's clinical case will be also discussed with Dr. John Chi, who is assistant professor in the Department of Neurosurgery at Brigham and Women's. Dr. Chi trained at Columbia, UCSF, and Johns Hopkins, and has published on a wide variety of neurosurgical topics, including minimally invasive surgical techniques. I want to also let you know that this presentation is being recorded, and we're going to be posting a video on our website. And so please, let's help me in welcoming Dr. Kowalski.
Good morning. Is this project okay? Great. My name is Matt Kowalski. I'm celebrating my 25th year in patient service next month, and chiropractic has changed quite a bit over the last 25 years. One of my goals when I first started practice was to work to integrate chiropractic into mainstream medicine, and particularly into the hospital systems. I was able to do that early in the 90s. From that point, we were able to assist through some key medical practitioners, chiropractors, gaining access into hospitals all across Massachusetts and across the country now. But today, to me, is quite a bit different. Today, this is quite an honor and a privilege to be able to speak here at Brigham and Women's Hospital. And I really want to thank Dr. Langevin for making the connections that she continues to make through integrative care, and to Dr. Levy, who has been our supporter and advocate for the last dozen-plus years here at Brigham and in all of our professions. So thank you both so much. I really don't, I have no disclosures to make. I have no personal financial interests, other than the fact that this gives me great personal reputational capital to be here. So thank you very much. So I have three primary objectives to present today. First, I want to familiarize you with integrative care at Brigham and Women's Hospital. The fact that, first of all, we do have a clinic, and it's over at 850 Boylston Street. We've been there for over 8 years now, and we're there because of we were started because of a philanthropic grant from the Bernard Osher Foundation and the continued support of Brigham and Women's Hospital. We're going to take a clinical case and identify some clinical intersections that occur between integrative care and mainstream or usual care with a patient with low back pain. I would love to be presenting to you a series of extraordinary chiropractic patients in their responses, but instead I get to present to you a group of extraordinary people and the care that they've been able to provide this patient in helping him through his journey with back pain and sciatica. And then the third part of this is I want to use this to also help you understand the scope and breadth of chiropractic care and what we do in the management of patients with spine pain. So we start with a patient in 2010 who was a gentleman with acute onset of low back pain, right lower extremity pain. But he has a backstory. And the backstory I want to first go into and tell you how this case evolved. He had 2 prior episodes of significant back pain that become important in the growth of our group is also in the treatment of the patient. The first episode was back in 2004, and you can tell us, this is our patient here is Dr. Levy, who is not only a patient but the medical director of the Osher Clinical Center. But you can tell, and this all began before we came together as a group. So back in 2004, Dr. Levy started with...
Actually, I never had back pain until I started in this clinic. I was 55 years old, and I stepped out of the shower, and I had the classic pain down my butt to my big toe. My big toe was weak, and my back was killing me, and the pain was killing me. And I arrived in the office to see Matt. Matt found me lying on the floor in some kind of a position that gave me some comfort. Should we say more about that?
Well, prior to that, he had seen his primary care doctor with this acute episode of back pain. He identified some weakness in his extensor hallucis muscle and said to him, we need an MRI. And so here's his MRI that you can see that at L5S1, there is a decent-sized disc extrusion here. But there are a couple of deranged discs at L4-5. He's a little bulge and an anterior bulge at L3-4. And so if you look at the transaxial here, you can see that it comes up and it butts against the nerve roots. There isn't a lot of substantial nerve root compression. And so Dr. Levy proceeded with the usual care, which was for you.
Actually, my physician, who's a terrific physician, said, you should go down the hall and see a neurosurgeon. And I said, no way. Sorry. I hadn't met John yet.
I agree.
Okay, good. I like that. Validated 10 years later. He said, well, you're on 6 Percocet a day right now. This is not a good long-term plan. And I agreed. And I said, he said, I'll give you a month. I know what you're going to do. You're going to try these things, some of which I don't know much about. And after 2 acupuncture visits, I was down to 3 Percocet, which was really astounding to him. And I actually felt a change in my back. Something happened. I was actually skeptical, thinking, how is acupuncture going to help? That disc sticking, it's a problem when a patient gets to see the picture of what's wrong, because that was in my head. And from that, I used some other techniques. We weren't formed as a clinic yet. I went to a local chiropractor I knew. I used acupuncture. There was a little bit of craniosacral therapy and massage, a few other things, and I got better.
Yeah, and to recap how it proceeded through, he had 9 weeks of care prior to the day I got to see him on the boardroom floor. And when I first examined Dr. Levy, my clinical assessment identified that he had positive neural tension signs. That is, when we stretched the sciatic nerve, it provoked pain down his back and his leg. When I raised the opposite leg, the same occurred, which is a cross straight leg raise. To me, which is one of the indicators that maybe he's not going to respond clearly to what I do. But I was also unable to reduce his pain at all through my clinical orthopedic assessment or through a manual assessment of the patient. And at the time, I'll tell you the truth, I hadn't bought into all the integrative approaches. And I had said to Dr. Levy, well, maybe we should go get that neurosurgical consult, or maybe we should try an epidural injection. But instead, proceeded on to, again, a trial of acupuncture, some manual therapies that included some chiropractic, and some movement-based therapies. It was in about a month that he had substantial functional restoration and pain resolution. And it was from beginning to that month later, there was a pretty substantial, profound change in that time frame. So I started to buy into this idea that maybe acupuncture and some of these other manual therapies can actually be beneficial for the patients that I didn't deem great candidates for what I did. And so I'm going to introduce you to some of the terminologies you'll hear and you'll see here. Feldenkrais method was one of the things that, one of the techniques that was used, Dr. Levy. If you can mention what that was for you.
Art Mador taught me how to take a look at how I use my body, and I'm actually doing something right now. I need to drop this knee. It makes, instead of being told how to sit, it helps my posture and my back be in a better position of function. And I'm also studied the Alexander technique, and this is in the same family of looking at how I use my body. Could that contribute to what's wrong with me?
So we went along, and he had full functional restoration at the end of about a month. But in 2007, he wanted to revisit the clinic again and developed another severe exacerbation of low back and S1 radicular pain. And what was the circumstances surrounding it?
I think that one was completely unprovoked. I just suddenly started to get the pain that reminded me of what happened 3 years ago, down the leg, back of the leg to the big toe, and I was not happy. Well, I can say there is a huge amount of suffering attached to low back pain that I think is overlooked and not acknowledged, and to not address that suffering is not a good idea. And what I had learned from the previous experience was the team addressed my suffering very much and made me feel that we can get through this. It's okay. Even in the middle of the night, if you can't get to the toilet, you can get into a position of rest. You can do this. You can do that. You'll get there, to the toilet, that is, and back. And I don't need to go to the ER or ask for more pain meds or get more films. So I had a sense, okay, here we go again.
So you can see his MRI here. Completely different picture than the last time. And he has a rather large extruded L5 disc extending up to the posterior vertebral body. And it's again, not causing a lot of neural compression, but it is a much more impressive one. And I got to evaluate him on this disc and said, I think we can help you on this one. And to his surprise, to Dr. Levy's surprise, it was, well, wait a minute, I have a big disc and you can help me, a small disc and you couldn't help me. The big difference was on the physical examination, we were able to start to relieve his pain during the course of physical examination through some movement-based strategies that we could use as a treatment tool, and I'll discuss as we go along here in just a little bit. Dr. Chi, when you look at this one versus the last one, do you have a...
Yeah, so there certainly is a visible change in the imaging studies, and one thing that we have the blessing of in a way are such great pictures that weren't around 50 years ago, and so this field has really changed in how we evaluate things. Looking at just these two pictures, there's obviously a change, and so there is a concern with that radiographic finding. But I have always tried to teach our residents and kind of beat this drum where you don't treat the pictures, you treat the patient. And I've seen bigger discs in patients who have gotten better by the time they've come into the office. And then vice versa, patients with even smaller that by the time they come in, things are 10 times worse. So though it's concerning radiographically, I think Matt's point is going to be, it's the clinical picture that really should dictate how aggressive or quick one does something, or the alternatives that you then can choose from.
Can I just say that the way John just spoke was as reassuring. I hadn't met him yet. We had a few years to go before I met you. Was as reassuring to me as the surgery, because he put it in perspective for me when I did finally meet. And I got the sense, I've been through this before. I can handle this. We can get through this together. That reduced my suffering dramatically. And he didn't look at just the picture. He looked at me. So I appreciated that from the start.
What you can also see here is that L4-5 disc protrusion that was present before is no longer there. This anterior L3-4 one isn't present as well. So his discs are dynamic. They are changing. And from the physical examination approach that we took, it was actually dynamic during that as well. We were able to reduce his pain during the physical examination, which to me lends to a much better prognosis. But then, of course, we used the other tools that we had within the clinical center, and what I have learned is that acupuncture for my patients with sciatic pain or radicular upper extremity radicular pain as well do incredibly well. And I always will offer my patients who have intolerable sciatic or radicular pain two options, and one of which is epidural injections and the other is acupuncture. And I say, let's give acupuncture a try. And oftentimes, by the time they get to that epidural, they've done substantially much better. He also received some manual chiropractic treatment, some joint mobilization, and craniosacral therapy, which we'll discuss in just a little bit. And integrated into this was the Alexander technique. Now, Arthur Medora is one of our movement therapists. Can you explain just a little bit about what Alexander technique intends to do? Oh, there she is. Hey there. Good. How are you? Good to see you, Kate.
Thank you. So the Alexander technique is a mind-body neuromuscular repatterning technique that is very much in education in addition to a therapy. So we re-educate the entire person. That's both a muscular re-education. So in Dr. Levy's case, it was actually focusing a lot on what he was doing with his neck and the relationship. There's a dynamic relationship between the head, neck, and back, and that we find when that's working correctly, everything else falls suit.
Something I had learned from Arthur is that our patients with low back pain oftentimes stand forward. They don't stand up. And just watch yourself get out of a chair. Oftentimes people lean forward and they use their back to get themselves up. And Arthur was able to help me with just simply teaching me to stand up instead of stand forward. So that subtle retraining through the Alexander approach was greatly beneficial and something that we all use in our practices as well. So now it's our current episode. It's November of 2010. Dr. Levy decides to take a long flight and comes back with a different pain. He has severe low back pain and right thigh pain as well. And he can't find a position of comfort. And so you can tell us how this proceeded.
This was, I was very used to L5-S1 now. It was my old painful friend, my back, around the back of the butt, down my leg, the outer thigh. Now I had a new one. This was going over and down over my knee to this part. I kept grabbing my calf. So I did go to med school and knew that this was probably L4. And it was remarkably painful, and it was very hard to get comfortable. And this was during the holiday season, and that was a miserable one. I know where the couches are at Nordstrom, where you can lie down. I found other places and other stores where you can actually stretch out, I was allowed to lie down near the changing room so my family could keep shopping and not have to drag me around. It really has an impact on your life, and that's what went through until January, I guess.
He tried a number of different approaches. He tried Medrol, Dose-Pak, Neurontin, Lorazepam, and then oxycodone provided some benefit. And he came to me for evaluation again, and this time I was clearly unable to reduce his pain whatsoever during a clinical examination. In fact, most movements actually aggravated his back and leg. A new MRI was performed, and Dr. Chi, I could flip through the next two. If you can explain more what we have here, it would be great.
So as Matt's been alluding to, disc degeneration herniations are very dynamic, and so over the course of these several years, we've seen one and then two, and now, in a way, a third area, in a way, arise. And so the disc herniation there where the red arrows show is likely a disc that came from L3-4 that was hitting the L4 nerve, which is consistent with where Don is describing that pain coming around the thigh a little bit, in front of the knee, and down into the lower leg. Again, when you look at 4-5 and 5-1, the ones that were highlighted before, you see that over time, those things have changed for the better, in a way. You don't see that large fragment that was there on the last MRI right behind the body of L5, and that's actually very normal, or it can be very, very common that you see these things go away over the course of years. But in this case, as the history dictates, this is a difference. It's a change. And again, you see this bulge at a slightly different area that stands out. Yeah, so, looking at both, it's all a very large continuum. So the way I describe it, and this isn't dogma in a way, but you can have tears of the annulus, you can have small bulges, you can have big bulges, and then what's a herniation? Well, some people think a big bulge is a herniation, while others think that a herniation truly has to be something that kind of extrudes outward. I call those ruptured discs, and then they come in small and medium and large sizes. And in this particular case, I think there was a small piece that actually did kind of break off. And again, to me, it's all the same thing. People always ask, well, oh my gosh, I have a herniated disc or I have a rupture. I tell them, listen, it's all in the spectrum, and it all depends on your symptoms. In this particular case, I think there was a little piece that you can see has kind of migrated a little bit south on that sagittal picture. Yeah, you can see how it just migrated a little bit south. And that indicates that there was a small piece. And the amazing thing is you can have big pieces that don't cause problems and small pieces that cause a world of problems. And it just is how it hits the nerve and how maybe it can be moved out of the way or not. So.
And in my assessment was, I don't think I can help. I don't think I can provide you relief. My thought at that point was, let's go straight to neurosurgery, because these are the ones I have seen probably respond the least favorably with conservative care. And we had several years of experience with our team at that time to make that determination. He tried an epidural steroid injection, which did not provide much benefit. And then Dr. Chi, you can tell us what happened after that.
Well, so I guess the beauty of this rounds and the beauty of this group is that we have a lot of different tools at our disposal. And I am definitely a firm believer, actually, just as an aside, there are only really 2 OSHA centers in the country, right? Oh, it's 5 now. Oh, 3 more got added? Okay. Since I operated on you, okay, good. That's good. But when I was in residency in San Francisco, we had an OSHA center. And when I came here, we had an OSHA center. So then I thought, oh, everyone must have an OSHA center. As it turns out, at that time, in 2008, there were only 2. And it was here in San Francisco. So I had had exposure in the past. And, of course, being on the West Coast, a lot of people came in wanting acupuncture or craniosacral massage or Tai Chi and all these things. So for me, it was comfortable and it was very familiar to have this group, and it was reassuring. The options, I think, are very important for patients with this, because I will definitely tell you, if I knew how to predict really accurately what needed surgery and what didn't, I'd be out of a job in a way, right? You wouldn't need me. And so it's very, very difficult. In this particular case, what we're seeing are recurrent episodes. Granted, not necessarily the same spot, but Don went through recurrent episodes. Sometimes this happens over months. Sometimes it happens over years. This is a very, very common scenario. And ultimately, it comes down to how the patient is doing, because like Don is saying, that pain can be so terrible and so excruciating. You need to be able to get some type of relief, and the patient themselves need to be able to physically and psychologically make it through the day. If you can't make it through the day, whether it's a toothache, I had 2 root canals over the summer, that pain is so all-consuming that you become disabled from it. And the real trick here is to understand, as a physician, but then also communicate with the patient, where they stand in this. And is there anything that can help? Is anything helping? What are we willing to not lose, but what are we willing to spend, in a way, in terms of time and endurance to make it through this? And I think what we've seen in the stories is that in the first episode seemed to respond pretty well. And the second episode also, to a certain extent, though it looked worse, responded. And I think it's that dynamic that's really important to understand. And I rarely try to take people immediately. These things really shouldn't be emergencies as long as the neurologic aspect is not prominent. And so there's the cauda equina syndrome that I think we're all somewhat familiar with, and even that definition can range. But for the most part, when it's primarily radiculopathy or sciatica and mainly pain, the last thing I want to do is rush in, because people will sign on the dotted line on our consent form. I can guarantee you people will sign on the dotted line because they think that you're going to get them out of the pain. And granted, we have a pretty good success rate, but that's not the case for everybody, and there are complications. And so even in this particular scenario, I would want to have that dialogue and see what's been tried, see what hasn't been tried, try to put it into a context. And we did that, didn't we, Don? I hope so.
And you fixed them, too.
But I think the important thing here is to try, even though it's excruciating, is to try to really put it in that perspective. And if you can, I think you have the options and patients will feel better. But there are times where you can't. And those are the patients that really do kind of hobble into the emergency room or have fallen because of it, because they've been trying so hard to deal with it and they just can't. And you have to then risk adjust in a way, or risk perceive how these patients are going to be doing, and that changes that decision paradigm. But in this case, it was great because we had the resources to have tried some manipulation, to have tried an injection, which all of these things, in my opinion, are things that I like to have up front, no matter how big or bad it looks in a way. Most times, for, again, sciatica or radiculopathy without the cauda equina issues, I like to try these other things because they're much lower risk than going into surgery. And if you can buy just a little bit more time, the body itself also is really the best healer, right? More than me or anyone else. The body can do a lot itself. And that's what I try to at least know, that the body's not doing that before we end up
When working with Dr. Chi, one of the things I've always been surprised at the number of patients that we've referred, and he said, no, go back and try a little longer, which is really builds up a lot with patients as well. We can go and say, here's someone who's not quick to operate, is willing to try everything along the road. And ultimately, Dr. Chi did perform an L3-4 hemilaminectomy, microdiscectomy, and I think you just answered that question I had up there. You answered the questions I had for you already. But Dr. Levy still had some postoperative radicular pain, which you could...
Yeah, it was healing, and actually it swelled up, and you took a look and said, I'm not worried. If you were sitting on your hand for 6 months and took your hand out, your hand has a little nerve damage. It's going to heal. And there's 2 supplements I have tried for people, sort of neuro-reparative, alpha-lipoic acid and acetyl L-carnitine. So I said, if you don't mind, I'm going to put myself on those. You didn't mind. And 2 weeks later, I was a heck of a lot better. I have no idea why. Could have been just the natural course, but a lot of healing took place over that period of time, and I tapered those off in about a month. I also wanted to say that it was really important to me that I asked you, what are you going to do? And you actually explained. He said, he's a micro. He does very little invasive work. He's going to go in there, make the tiniest hole, pull that piece of disc out, take a look that there's no more disc ready to plummet into the same spot, and close up and goodbye. And I like that very much. So.
And it did great. I mean, it continued to feel wonderful, but had to do it just one more time in 2013. And at that time, we had seen Dr. Isaac, who was able to provide selective nerve root block and provide relief pretty immediately after that, right? First night of sleep was after the epidural injection.
That's right. There was the last episode after this, the one that we presented today is the main case, was 3 years later. And that one, there was intractable pain. I could only get relief standing up. And so after 23 nights of very little sleep, watching the girl with the dragon tattoo, whatever, at 3 in the morning, or other movies I didn't know still existed, standing up until I got so exhausted I could fall down and go to sleep for a while. Zach Isaac, found that the injection was remarkable. I slept for the first time in like 24 days. And that's when I'd also began to use the Alexander technique more. The article had come out in 2008 about the success of the Alexander technique in England, and so I went to Kitty over there many times.
Where are you today? Just so we can wrap it up.
Today I'm back to my ornery self. Occasionally, there's been a lot of snow, and if I overdo it, I can feel a little bit of numbness. L4, L5, and L4 are familiar to me. They're minor, and I still get flare-ups. I go for various therapies, and I get out of them. Sometimes I need oxycodone for a few days, and then I'm better. I'm generally doing whatever I want right now, so I'm back to living my normal life.
And so decision points developed along the way here. And part of some of these decision points are things that I want to highlight and bring to everyone's attention, that there is a usual course of care, but we can bring in some not so usual treatment options. For example, when the patient is unable to relieve the pain, do we need pain management or physiatry, or can we try a trial of acupuncture or try a trial of chiropractic, even for a finite period of time, a couple or a few weeks even, while the patient's waiting sometimes to get their interventional procedure. Excuse me. There are clear-cut cases that we need surgical consultation. And then when we move into the patient with the recurrent episodes and deconditioning, do we go to physical therapy or do we go to something else? And how do we match that up? How do we get the patient, pair the patient up with movement therapy versus physical therapy? And I'll address that just as we move along in just a little bit here. And then if the patient doesn't have clear musculoskeletal pain, do we pull in primary care or physiatry or mindfulness-based stress reduction programs? What's amazing to me is working with Dr. Paulson here, and you can introduce who you are. He's Dr. Paulson runs a mindfulness-based stress reduction program, who's treated, has had patients with acute and chronic low back pain in his program, who without touching them is able to relieve their pain through the mindfulness-based approaches, which he has taught us to integrate into all of our care. So, what do we learn here? Hey, there's some disarrangements that self-resolve, some don't. But I don't think we need to look at this versus integrative versus usual care. It's all integrative care. We need to pull pieces together at any point along the line and ask the patient, if this is something that is appealing to them, that they have the resources for, or that we can integrate in. So there are some other than usual approaches that we can present, choices along the way here. And there are also multiple points of entry for spine care. And I'm comfortable with any of the practitioners within our clinic being an entry point for spine care. But as a chiropractor, I'm going to tell you a little bit about, I'm going to switch over to the chiropractic side for a little bit here now. As a chiropractor, I can tell you that we see lots of patients with neck and back pain. In fact, if you look through Optimum Health, what their statistics are is that 74% of people with an episode of back pain see either a chiropractor or a primary care physician initially. 40% of the population will see a chiropractor first. So we are a common portal of entry for patients with spinal problems. I look at this as a growth opportunity for Brigham and Women's Hospital to bring those patients in. There's 40% of the population we're probably not pulling in on a regular basis. Also, I look at this as an opportunity for chiropractors to help primary care physicians to offload some of the patients that may be headaches to them or backaches or neck aches to primary care. If you look at patients who are under care for neck pain or back pain, about 47% of them will have seen a chiropractor in the last 4 weeks. On this one study, on this one polling that was done, we see a lot of patients with neck and back pain. So what do we do? What is our chiropractic approach in the Osher Clinical Center, and how does it feed in? How does it weave into the other therapies that we use? All of our chiropractors are trained to screen the patient for red flags. That is, do they have indications of cauda equina syndrome? Do they have indications of infection, cancer, fracture? So we do a screening procedure that everybody actually does throughout our clinic, and we, included in our research study that was just recently wrapped up. We look to make a clinical diagnosis, and we do as chiropractors, try to determine whether the patient's pain is referred or radicular and the severity thereof, and perform a mechanical evaluation in addition to the traditional time-honored evaluation procedures. One of the things we do as a clinic is honor the patient's goals, their therapeutic preferences, and their tolerances to the problem. We'll always question the patients provide them what the options are and let them make that informed decision along the way as we have these clinical intersections. All of our goals are to relieve pain and restore function. And of course, we want to limit side effects, improve patient satisfaction, maximize the patient satisfaction and independence, as well as control the costs. So my mantra as a chiropractor is this: address the suffering. Then I want to centralize, stabilize, mobilize, and optimize. And so as I go through this rest of the program, is all going to be based around that construct for patient for low back pain management. So the first thing we want to do is to not contribute to the patient's suffering. And this is great conversations we've had with Dr. Paulson and also with our ethnologist who has followed this program since its inception. And I always say, you know, when you first see a low back pain patient, you have the opportunity to treat a patient with low back pain or to create a low back pain patient. And the use of the language that we have up front can create that low back pain patient. And I think we need to examine our lexicon. And there was one small study that did that. And when patients were asked, what does nonspecific back pain mean to you? One of the responses, common responses are, the healthcare practitioner doesn't know what they're talking about. They don't understand the problem. And we use these terms all the time, pretty routinely. You have wear and tear in your back. Well, what's happening? My back's about to give out. It's rotting away. This is a terrible thing that I don't have to go through for the rest of my life. How many times do we use the word instability? Patients may interpret that as the back could give away at any time. Or even just the word chronic was interpreted by patients as this is something that's incurable. And one patient said, I'm a couple of steps away from a wheelchair. So I look at that lexicon that we use in communicating to our patients with back pain and do exactly what Dr. Chi was saying. Say, hey, we can't treat your MRI. We got to look at you. And in fact, Dr. Levy came back. I remember coming back and saying to me, yeah, I had this post-operative pain. I went to Dr. Chi, and he said, it's okay. It's just like pulling pressure off a nerve. It's going to come back to life, and you're going to feel some pain there. And he was able to completely treat his suffering versus create another procedure that needed to be done. I think that this actually should go into diagnostic imaging as well, as we have transparency in our records. And we look at patients who are able to pull up their x-ray reports, and they come into us and say, oh my gosh, I have osteophytes. Or I have disc degeneration, and they come and label themselves as a disc patient. So we need, I think, to have some kind of an educational program for patients when they are diagnosed. So my treatment goals are, again, let's not contribute to the suffering. Let's talk the patient down and help control that suffering component. Next, I'd like to centralize their pain. Now, centralization comes from the McKenzie method approach, which means progressively drawing the patient's symptoms away from the distal extent. And what happens is, as the patient's symptoms are relieved, they become more intense proximally until we bring the patient's pain to the midline and treat the midline pain. It's theorized that the examination and exercises that we give the patient to do change the tissue dynamics and relieve pressure on the nerve, and as it provides the patient with relief. And when I was telling you about case number 1 with Dr. Levy, I was unable to centralize his pain. That gave me the idea that maybe I'm not the person to treat him. Case number 2 with the big disc herniation was able to centralize his pain while in the examination. Case number 3, completely unable to do so. So it gave me, to me, it has prognostic value as well as treatment value. And so at the Osher Center, what are some of the things that we do? What are some of the tools that we draw from besides the conventional care? Acupuncture is a big tool that we use, and I, again, have found it to be great for radicular pain, and Dr. Levy can provide references for that, I believe, yes? For acupuncture for radicular pain. Yep.
There are responders and there aren't responders. And that's the big issue, and you just give it a six-session try.
One of the things that I use is what's called the McKenzie method, which is a tool, which is a treatment evaluation procedure where we try to teach the patient movements that take the pain and centralize it. And we teach the patient to do those movements at home so they can become independent of care, and oftentimes will require some hands-on therapy to make that occur. We also use craniosacral therapy, and Dr. Levy had craniosacral therapy the night before his surgery. For a tool to help him relax. And we have Jifan Roche is here, who is our craniosacral therapist, and I will, she's right over here, and I'll pop up her quote here because I can't do it justice trying to describe craniosacral. The patients may be candidates for mobilization or manipulation as well. Tom Jacobson was integral in trying to find relief for Dr. Levy. And Tom, if you can tell us what you do. Tom is a massage therapist and movement therapist, a yoga instructor as well.
This patient was typical in that he presented with a complex and unique history. He was healthy and active, and most important for the referral to my practice, he was motivated to learn new approaches to self-care, which could be immediately effective. Too often patients are told simply to relax and rest and to keep moving. I mean, we hear that all the time. But they're rarely instructed in how to safely do that while in the grips of strong pain and loss of confidence, which we're starting to see pop up a little more with the expression kinesiophobia, people who actually develop the habit of being scared of moving. My work involves massage therapy, combines massage therapy with individually tailored, relaxing, yoga-based movement therapy. When movements and ADLs are painful, some patients respond well to very small, simple movements, which minimize muscular effort and allow them to reestablish confidence through the direct experience of pain relief. Instruction in a position of constructive or mindful rest is foundational to breaking this cycle of pain causing increased tension, worry, uncomfortable movement, feeding back into more stress, more pain, etc. My approach involves teaching how constructive rest can break into this cycle by safely unwinding muscular tension and reducing pain and stress.
Thanks. Thank you. And craniosacral therapy is the most gentle therapy I've ever received, and it uses about 5 grams of pressure to treat fascial restrictions within the craniosacral system. G was able to use this for relief of some of the acute pain for Dr. Levy, but also he came to her the night before surgery to provide deep relaxation for the analgesic effect of craniosacral therapy. It's a treatment that I honestly can say you have to receive it to understand it, because it's hard to understand how 5 grams of pressure can provide profound changes in the soft tissues, but I think we've all experienced it. Any comment, Jean?
2 points. I think craniosacral therapy, it's very gentle manual therapy. So you can usually treat the patient like newborn babies to more than 100 years old. Doesn't matter if you can live 200. Because this light, like the weight of nickels, so for the case like a patient of the babies with a lot of spasm pain, so we be able first to relax him very quickly to be release all like fascia tension on the pelvic and the abdomen, and also gentle, mobilization of sacroiliac joint. And because craniosacral therapy, we do focus in the central nervous system. So, and just hope the dural membrane to be more flexibility. This really relieve the tension on the nerve system. So before his surgery, so my background also PT. So I usually do pre-surgery and post-surgery. So I mix with craniosacral therapy to be able to prepare patient in the very relaxation stage to whenever create a space so patient can be ready to surgery. And I think Dr. Levy was totally fall asleep that day. I probably need to wake him up. And also because we also work with fluid exchange in the system. So I think there will be hope later for the healing system in the different layer of system.
Thank you. So we know what our medical approaches are for centralization. We have all of these tools, from interventional pain management to oral medications. I think, though, with the growing concern about the use of narcotics, particularly as an entry point in low back pain, we could provide an alternative to or complement to many of these many of these oral medications that are being used. To stabilize the patient's spine, I always start with a program of core stabilization where we teach the patient to activate what's called their transverse abdominis muscles and their multifidus muscles. What's really neat is our physical therapy department at 850 actually has real-time ultrasound to help them visualize these muscles and teach the patients to contract the proper muscles. It's a great tool. It's a great service that they have there as well. Now, here's a decision point that I always go through with patients to say, we need to get you active. We need to try to combat kinesiophobia. We need you to move. And so I always ask the patients, are you a person that needs structure? Or are you a person that can do this in class? Or do you want me to teach you how to do it at home? I like Tai Chi and yoga as great tools to integrate movement into the patient's life, to reduce kinesiophobia. And for those patients who simply aren't candidates for that for their own choice or for availability, structured rehabilitation programs in physical therapy or even in our offices are being used. As far as mobilization goes, we like to, again, centralize, stabilize, mobilize. That mobilization may be in the form of soft tissue or articular mobilization. And the goal in my practice is to optimize intervertebral as well as peripheral joint function to restore mobility. As a chiropractor, I have been kind of equated with spinal manipulative therapy. What is spinal manipulative therapy? It is a high-velocity, low-amplitude impulse applied to a joint at its end range of motion. And what's happening here is that the clinician is using the spinous process and the ischial tuberosity as levers to apply an end-range stress to the joint and then a very quick impulse to the joint to mobilize it. It's not always appropriate for patients with disc-type derangements. We may grade that procedure down to something that's called grade 1 to grade 4. Spinal manipulative therapy, in my practice and in our experience, has been extremely good for treating patients with facet syndromes, mechanical spine pain, or mechanical sacroiliac joint pain. Another tool that we have at the center is what's called flexion distraction therapy. And with this therapy, the patient is able to lie prone on the table, and we can place a hand underneath the spinous process and use that as a lever contact as this table is deflected inferiorly to create a traction effect at as close to specific intervertebral levels as possible. The table also applies continuous passive motion to the patient to decrease interdiscal pressure as well as to mobilize the patient's spine. I find it great for patients with facet syndrome, disc derangements, and particularly good for patients with spinal stenosis. Chiropractic in the clinical practice guidelines in the Annals of Internal Medicine has a, sorry, that's hard to read up there, has a level of evidence of good and the net benefit of moderate, which ranks up with many of the other procedures that are being used for treatment of back pain. So how do we select a patient with spinal manipulation? First thing is rule out contraindications, which I'll tell in just a second. Second, we need to find a clinically significant mechanical lesion and then test the patient before we manipulate them. Put them into a position where we can stress the joint before we actually apply that force to make sure that they don't have an adverse effect. And then administer a short trial of care, usually between 2 and 4 weeks as an initial trial of care. The best candidates are the patients with low back pain with or without some referred lower extremity pain with little radicular symptoms. Patients, again, with sacroiliac joint pain, mechanical sacroiliac joint pain also respond quite favorably. There are contraindications to manipulation. Of course, patients with cauda-equina syndrome or progressive neurological deficits, patients with some acute disorders, arthropathies and fractures, or substantial demineralization of the bone, spinal instabilities, infection, malignancies, are all obvious contraindications to manipulation at that area. Is it safe? There have been estimates from 1 in 20,000 patients will have an increase in pain to 1 in 38,000 have progressive radicular symptoms. In my experience, about 1 in 5 get sore after treatment. It's not uncommon at all. The possibility of developing a cauda-equina syndrome is 1 in many millions, according to Haldeman, and 1 in about 100 million, according to Shakel. So the possibility of taking a healthy disc and creating a cauda-equina syndrome is very low. The factors that have been associated with complications or misdiagnosis, failure to recognize that the patient is going south, or an improper technique applied to the area. I don't want you to equate chiropractic with spinal manipulation. Chiropractic is a full, it's a complete healthcare program or system where we diagnose and treat patients from the beginning. We're licensed to examine patients, to perform a differential diagnosis, to order and interpret diagnostic testing, where our treatment strategies can include spinal manipulation, but also rehabilitation, ergonomic training, soft tissue techniques, as well as case management. It was just much of what I had done with Dr. Levy. And ultimately, our therapeutic goal is to optimize function. We get higher levels of stabilization, rehabilitation, and all of us work to do that in our clinic, and we work with physical therapy to do so. Sorry, I had to buzz through that back end there because we only have a couple minutes left. Sorry. This is our clinical team. This is what we offer at the Osher Center. Dr. Levy does integrative medicine consultations. We have acupuncturists, chiropractic, craniosacral, massage therapy, mind-body therapy with Dr. Paulson and Meredith Beavisar. We have massage therapy, nutrition with Caitlin Hosmer, who is here, and Tai Chi with Dr. Wayne, and yoga and massage with Tom Jacobson. Can our team just stand up real quick just to show who your faces are, and this is who we are here. So I hope I have accomplished this to familiarize you with what we do, with what chiropractors do, and understand where some of these clinical intersections can occur. I know we have 5 minutes to have some exchange here. Sorry that it's so tight, but Dr. Langevin? Yes, sir.
Hey, Don. It's so nice to see you, and I'm so sorry you've been going through so many things recently. What's really interesting to me from this presentation is, before all of this, how do we actually prevent these ruptures and these injuries and these discs? Because so much of integrative medicine is about creating wellness, and so this is very much on the medical model that something is going on and then you treat it. But what are the things that we can do that can really help to prevent this happening in the first place? And that's a puzzle that I hope you can answer.
And I think that's the greatest of questions, and that's what we were talking about that again this morning. That isn't it wonderful that we can treat all these problems, but wouldn't it be great to be able to prevent them? And the question is whether our tools for prevention are actually beneficial. Arthur, you had something you had said earlier today.
One of my main contributions is assessing the current strain factors in a person's sitting, standing, moving, what you're doing with your back most of the day, and then figure out ways of dividing that effort into more body parts or integrating it. So that's my approach. I know in Dr. Levy's case, as in so many of the people here, we're all big sitters, and sitting is a tough on discs. So there's lots of things, and you have to prioritize them.
And I think, I mean, just movement in general, getting our patients away from a sedentary lifestyle and integrating movement. And my discussions with the patients are, what movements will appeal to you? We can do it in the class. We can do it in Tai Chi. We can do it in yoga. We may have rehabilitative approaches as well, but sitting is probably is kind of like the cholesterol of the low back. Dr. Chi, any?
Yeah, I think it's a great question, and I think we are going to get more of an understanding of this. The bottom line is that anything can make things worse in the back, and lifetime genetics, hereditary, certain injuries, exposures, etc. I do think anthropologically, in a way, as we as bipeds, we're intended in a way, I guess our spines are really more designed to stand, right? We're not designed necessarily to sit in a chair like this, maybe sit on the floor with our legs crossed, maybe, but we're designed really with the curve of the spine to be supported when we're standing and then lying. And I do think in the modern era, we are all much more sedentary than we were even 100 years ago. I think the average office worker even walked, right, 100 years ago. They didn't have cars as much. So I do think that our lifestyles, the modernization of our societies, have contributed to this. We now routinely take 6-hour plane flights, several times a year, right? That wasn't even common 30 years ago, to be on a plane that long. But I think all of these things contribute, and the desk work that we do and all of these things contribute to that. So how do we prevent it? Well, I think it's multifactorial. It's all the things that we've talked about. Using proper body mechanics, understanding the difference between sitting for 6 hours versus getting up every 45 minutes like the recommendations are supposed to be, getting regular exercise, building up your core, doing certain things to prevent. You can't avoid getting hit by a car. A lot of patients get hit by a car, and then they're just doomed for life in a way, unfortunately. There are genetic components to degenerative disease, and I think there probably is a specific subset that attacks the spine itself. Aside from, say, knees and wrists and shoulders. That part hasn't quite been elucidated. I think there's probably dietary factors. I think people's autoimmunities can come into play here. as well to increase the inflammatory response that someone gets to a flu or to a minor injury that then turns into more. So I think it's a very, very broad topic that would be great to start to study and investigate in a more thorough way. But ultimately, it's all of these things, and that's how I explain it to patients. And having had my own family members who have had these ailments, it's not like we have a certain type of risk factor, but I think everyone is at risk. It keeps us all employed, right? But we're all at risk.
Probably one of the people who has a harder job in our clinic is Caitlin, trying to get people to change diet and change the things they're putting into their body to create inflammation. And we have time for one more question, and I saw a hand up in the back, and I know Dr. Paulson wants to say something too. So if we can.
Quick question. As good as yoga and Tai Chi are on so many levels for stress reduction and for exercise and part of this rehabilitation and getting people to move again, how do you advise your patients to do things safely if they want to go take their own yoga or Tai Chi class? Are there things they should avoid, like twisting and bending and things that could exacerbate their condition?
One of the things I always tell my patients, it's okay to bend, it's okay to twist, it's okay, it's bend, twist, and lift, but I don't want you to do them all at once. So it's the BLT of back pain. I always tell the patients, with disc derangements, I try to avoid repeated flexion postures in the early stages. That may be something we integrate later on. And so I do coach my patients that I refer to yoga to avoid some of those heavily flexed positions because of the disc dynamics. You're welcome. Dr. Paulson.
Yeah, I just wanted to address the issue of prevention and what we mean by that, because listening to the case this morning, there's a way in which disability has been prevented along the way. It's not just preventing the occurrence of a bad illness or an injury before it happens, but preventing things like kinesiophobia or restriction of lifestyle after an injury or a surgery. And the one characteristic I think that links all of these presentations is the notion of a conversation, that Dr. Chi and everyone else is entering into a conversation that, in a sense, invites the patient back into their own house, if they think of their body as a house. And we've all had our houses under stress the last month, and we can see that an inhabited house is much more able to resist injury and difficulty. It's much more able to do that than an uninhabited house. So awareness and mindfulness really can be invited by a conversation or giving people into a simple practice of tuning into their breath, such that Dr. Levy joins this treatment as a partner and a homeowner of his own body, and that brings that self-healing quality into the interaction, and that's, I think, what we're about.
Thanks. Helene?
Well, thank you so much, Dr. Kowalski, Dr. Chi, Dr. Levy, and all of our wonderful practitioners. I think we can say safely this is an excellent start to our Integrative Medicine Grand Round series. We're very, very pleased, and I want to make sure that you all are aware that our next Grand Rounds is going to be on May 5th. First Tuesday of May. There are no Grand Rounds in April because there's actually a presidential function happening here at Bornstein that day. But after that, we will be the first Tuesday of every month, right here, 8 o'clock. And so I hope we'll see you back regularly. The next Grand Rounds is going to be hosted by the Benson Henry Institute, and a case of Crohn's disease is going to be discussed. And also, I want to tell you that there is going to be a CME course on mind-body medicine and cardiovascular health that's jointly organized by the Osher Center and the Benson Henry Institute. And that's going to be on May 1st. And there are some flyers right here at the door if you want to pick up flyers on that. And please be sure, if you have not already signed on our sign-up sheet, and there are CME credits available for this class, for this lecture. And It's also being videotaped, and so it will be on our website. Thank you so much again.